Welcome to the Alliance for Patient Care, an organization dedicated to advancing smarter healthcare policies that empower both patients and providers. Through innovation and advocacy, the Alliance supports stronger, healthier communities.
Hi, everybody. Welcome to another Alliance for Patient Care webinar. This is the third one in our patient care series focused on wound care. And as many of you know, there are some pretty significant changes in front of CMS right now in the wound care space, specifically when it comes to skin substitutes. So our goal with this webinar series is to make sure that providers and patients and policymakers all have the right information when they're thinking about wound care. There's a lot of bad information out there. I'm sure many of you have seen the New York Times hit pieces on advanced wound care and skin substitutes, calling skin substitutes expensive bandages, which is probably the most derogatory thing I could think to call this wonderful technology that we now have access to in the modern era. And we're getting good traction on these. We've had plenty of watches on the replays. Our social media is great. Please follow us on Facebook and LinkedIn. And we have a great webinar planned for you today. But first, let's just touch on a few pieces of the Alliance for Patient Care and what we are working on. So the Alliance for Patient Care has three goals: advocacy, connection, and education. We are actively advocating for you all in DC. We're working legislative connections. We are working through grassroots to advocate for, right now, our focus is skin substitutes and wound care, but we'll continue expanding that in the future. Connection. We really want to connect providers with patients, patients with providers, and providers with resources like Dr. Natalizio, who's going to be on today, who have expertise that is going to be useful in advancing patient care overall, because the real core of what we do here is education. We want to educate providers, educate patients, and educate policymakers so that everybody can make the best decision for their health, for their patient's health, and for policymakers to make the decisions that empower patients and providers to work together without big government in the ring. Many of you guys know we send out emails about it. This is a huge piece for any provider who is touching the wound care space right now. There's a proposed CMS rule change. We went into how that affects providers pretty in depth on our previous webinar, which you should be able to find on YouTube. If you can't find it on YouTube today, it'll be up tomorrow with Yvonne, who is a mobile wound care provider in Florida. And we talked a lot about how $125.38 a centimeter is a 90% or 95% reduction in overall reimbursement for skin substitutes. And they came to that number by only looking at hospital data, which, as Yvonne touched on, it's very different to have hospital data versus home care data or mobile care data. The 60-day comment period closes on September 12th. Please go comment if you haven't already. Please share it with other providers in your network. Please share it with other patients in your network to make sure that we can get as many comments in as possible with CMS ahead of this rule change. Again, submit comments. You can also, one thing I didn't touch on the last slide is call your senator or representative and tell them that you oppose the rule change. They do have the ability through constituent services to reach out to CMS about this. The more they hear from you, the better. Today, we have a very special guest, Dr. Amanda Natalizio. She is the founder and CEO of Helix Molecular Solutions. She is an expert in the lab space, and we're going to be getting into how labs and how testing impacts wound care. So this is kind of a different discussion from our previous two, where we touched really heavily on skin substitutes. But today we're going to touch on PCR testing and why that can be so useful in your wound care formulary. I know we received a lot of questions last week about kind of the overall wound care formulary, particularly from the perspective of providers who are just getting into this space. I'm going to let Dr. Natalizio take this away because she can speak way more intelligently on the lab space than I can. But Dr. Natalizio, it's so great to have you on today.
Thanks for having me.
So
yeah, my experience. Yeah, my experience mainly is in the clinical diagnostic space with biology and molecular genetics. And today I'd like to focus on wound care and how PCR testing can help with chronic wound treatments.
Awesome.
So chronic wounds, as many of you know, are a problem in the U.S. 6.5 million patients a year are impacted by chronic wounds. And this is rising because we have increasing rates of diabetes, obesity, and vascular disease. And 37 million Americans have diabetes, and up to 25% of those will develop diabetic foot ulcers, which often will turn into chronic wounds that need treatment. And this is very, very costly for the U.S. healthcare system, with over $25 billion annually. There are some estimates where it's closer to over $30 billion annually. These chronic wounds, non-healing wounds, drive ER visits, hospital stays. There's costly interventions and even amputations. And these costs are magnified when the wounds become infected or the grafts fail for these patients. There's a major problem right now with antibiotic resistance. And in fact, wounds can rapidly get worse, leading to sepsis, limb loss, or even death. There's oftentimes many of these chronic wounds they have biofilms that make the wounds resistant to standard treatments and antibiotics. So they fail to heal because of these biofilms and resistance. And who has been warning for years about a post-antibiotic era due to antibiotic resistance and overtreatment with antibiotics, where providers will treat empirically for UTIs, or maybe they will be for wounds with antibiotics, broad spectrum antibiotics, when they aren't necessarily needed. So early detection and targeted therapy is really essential to help fight antibiotic resistance, and also to help with these chronic wounds, to identify what is the pathogen and is there resistance in these wounds. So it's not just about the cost to our healthcare system. There's impact on quality of life for these patients with chronic wounds. They have, persistent pain, loss of mobility, depression, isolation, and it can lead to loss of independence and need for long-term care. So there's not only the healthcare costs associated with this, there's loss of productivity in the economy because these people can't work. And so they're not able to improve our economy by adding to the workforce. And as we know, the amniotic allografts and new precision diagnostics is really evolving as standard of care in the wound space. So providers are shifting to regenerative medicine, advanced biologics like these allografts, and precision diagnostics like PCR. Evidence-based protocols emphasize infection control and wound bed preparation. And payers are demanding documented outcomes. And diagnostics like PCR add to strategic advantage because, again, it's a precision diagnostics that you can identify what's infecting these wounds and are they resistant. So for these chronic wounds, infections is a top reason that's been present in chronic wounds. And these biofilms protect bacteria and make them up to 1,000 times more resistant to antibiotics. So in these biofilms, they basically have this slimy substance that's produced protecting them. And frequently these biofilms, they're not just one type of pathogen, one type of bacteria. There'll be multiple. And many times they are in this lower metabolic state, which helps them to be resistant to antibiotics. And it may not necessarily be that they have a resistance marker or gene, but they're phenotypically, due to their low metabolic state, the action of the typical antibiotics require a higher metabolic state for those antibiotics to actually be useful. So these biofilms make it very tough to treat when they're present, and they're frequently present in chronic wounds. And this antibiotic resistance, not just from resistance genes that they may carry, but due to their low metabolic state in the biofilms, will prolong the infection and increase the risk of sepsis or amputation. And these wounds just fail to heal oftentimes in these cases. So our standard, the gold standard, has always been considered culture. But now that we have molecular diagnostics like polymerase chain reaction or PCR, we've found that when you compare the two, culture is oftentimes falling short, in particular with chronic wounds. Culture is going to oftentimes miss key organisms because infections, UTIs. So it's biased towards growing E. coli, typically, because E. coli is going to cause 80% or so of UTIs. So culture is really good and lab protocols are really good at growing E. coli, but culture is not great at growing other organisms. And you have to have different media, different conditions, different, oxygen versus CO2 versus which nutrients you have in your plate to grow these organisms. So if you're only really mainly biased towards E. coli, you're going to miss all these bugs that require a different media and different environment to grow. So traditional culture is going to fall short, and you're not going to identify a lot of these pathogens that are hard to grow or slow to grow. There are organisms that, yes, we can grow, but oftentimes it'll take several days and sometimes weeks to grow some of these. Whereas if you do PCR is very rapid. Once you get the sample, a lot of labs, they can get that turned around the same day or next day. Culture, even the fast growing bugs, that's several days because you have to grow them, isolate them, grow them again, identify. And then the slow growing ones, sometimes you just won't see, or if you don't have the right conditions because you don't know what you're looking for in these wounds, you're not even going to find it because you didn't have the right conditions to grow the pathogen that you didn't know you were looking for. Whereas changed by if the patient's on an antibiotic, the results aren't going to be impacted. And you don't have to specifically put a particular condition down. Doesn't matter what the bug is, as long as you're testing for it, you're going to see, is it in that patient's specimen? So biofilms, you're not going to have that with PCR because these biofilms, again, oftentimes these bacteria are at these lower metabolic states. They're not in a high growth phase, so they're very slow to grow. You're oftentimes just going to get like the predominant bug that's in that sample, and you're going to miss some of the other slow growers. Or these bugs that are in a lower metabolic state, oftentimes in these biofilms. But when you do PCR testing, as long as you had a good collection, it's very, very sensitive. You can just think about, we can identify dinosaur DNA and sequence dinosaur DNA. That is super old, right? You can find it and you can sequence it, and you can do PCR and identify it. So if you're that sensitive to be able to look at dinosaur DNA that's millions of years old, you're going to be able to identify the bugs that are in a sample to a very, very high sensitivity. So there are a lot of studies out there, and research is consistently showing that molecular testing is more sensitive than these traditional cultures and has a strong potential to enhance patient care. And I just want to touch on a few studies that are out there. There's one study that 13% of culture-negative wounds had pathogens detected by molecular methods. So in that particular study, 13% of wounds that they cultured, and there's nothing here, this is not an infection, 13% of those, PCR was able to identify that, yes, there was a pathogen in those wounds in that sample that was tested. And I'd already mentioned that cultures are often only going to identify the predominant pathogen in the sample, but 50% of the time, there are more pathogens in that sample. So in these biofilms, frequently, it's not just one bacteria. But in culture, you're often just going to find one predominant, and they're just going to report out, oh, you've got this one bug. Okay, I'm going to treat based upon that one bacteria that was identified. But there could be 1, 3, 4, 5 other pathogens that are actually in that biofilm or infecting that wound, and those aren't being treated. And so now those take hold in that wound because you didn't know that they were there because you only used traditional culture. There was another study that showed that DNA testing revealed 338 bacterial types versus 17 in culture. The number of pathogens that are actually in these wound samples that aren't being identified by a traditional culture. So it's really falling short in many regards. So as I'd already mentioned, molecular testing is definitely more sensitive than traditional culture. And so it can provide information that can directly improve patient care. So if you know exactly what pathogens are present and you're doing antibiotic resistance gene marker testing, you can then provide treatment options for that patient that are going to treat all of the pathogens in that wound. Additionally, once you identify what they are, if you wanted to then supplement with a traditional culture on top of that, that can provide actually some extra information where, once you know what to look for, they can then alter how they're doing the cultures to grow the specific pathogens that they know were present by PCR. Because again, different pathogens grow in different conditions and different media with different nutrients. So you can do both tests, but you'll have better success with the culture if you've been able to identify with PCR what pathogens are present. So again, these wounds are containing multiple pathogens most of the time, especially if there's biofilms. And so when culture is only identifying this one predominant one, this PCR is going to be more sensitive, and you're going to be able to detect these other pathogens. And this because of the drawbacks and pitfalls of culture. And so again, typically these patients are going to have these chronic wounds that aren't healing because they don't know, that the provider doesn't know what pathogens are actually present. And so they are not giving the best treatment to the patient because they don't have all the information that they need about that wound, because culture isn't able to identify all of the co-infecting bacteria. So as I'd mentioned, speed and sensitivity is superior for PCR to detect not only the pathogens, but the resistance marker. Instead of waiting days or a week for your traditional culture results, you can have results same or next day. You can have broader detection where you can identify in these biofilms multiple different pathogens. And you can also identify antibiotic resistance markers. So these results, by same day or next day, you can get the best guided therapy for these patients rather than waiting weeks and weeks and then treatment's failing and you're still seeing this wound not healing because you're not treating with the right antibiotics because you're missing things from culture. To provide the best therapy for the patient to treat with antibiotics, that then can also improve graft outcomes because you're ensuring a healthier wound bed that's been properly treated with the right antibiotics. So overall, bringing it together, really this is like a teams-based care. The labs are essential for treatment for chronic wounds to provide the right information, accurate information in a timely manner to providers to treat their patients accordingly with whatever therapies and biologics to help facilitate wound healing. And really education is very important. So I appreciate this platform to educate providers about PCR because there are a lot of misunderstandings about what it can offer. And culture has always been the standard. PCR is a newer technology. And there's sometimes some payer issues with reimbursement and things like that labs are oftentimes fighting back to get paid. And there's lots and lots of publications, peer-reviewed publications out there and I had just touched on some of the stats about how sensitive PCR is and how traditional culture is missing not necessarily just about educating providers about PCR testing, and these things I'm sure everyone knows takes time. They're always sort of lagging behind where we're at with medicine. So I think the future outlook for treating chronic wounds is going to be this combination of molecular diagnostics and regenerative medicine being sort of the standard. And hopefully, the payers will sort of catch up with being on board with what's the best treatment and the best outcome for the patient, because we're getting more and more data to show, okay, what's the outcome if you do PCR versus traditional culture, or if you're doing these allografts versus traditional coverings. But PCR just isn't about the speed of the test. It's about smarter treatment and better documentation and ultimately better healing and better outcomes for these patients.
Awesome. Great presentation. Thank you for that. I do have a few questions. And as a reminder, if you guys are watching this live, you can drop your questions in the chat. I know that a lot of people who hop on are providers, and this is generally when they're wrapping up lunch and maybe heading back to patients. You touched on documentation, and that's something that both Blake and Yvonne, are two of our previous guests, touched on as being so crucial to the wound care space. Can you just tease out a little bit more, like the difference between documentation in a PCR tested wound versus a traditional culture tested wound?
So a lot of times you'll get a report for a culture. Oftentimes a culture report is not super specific about the particular strain of bacteria or virus or whatever pathogen it may be. They'll sort of typically more broadly classify what they've identified. Whereas PCR is much more specific to the strain, the species. It won't necessarily always be a genus level, although there are some that are genus level. It just depends upon the lab. And there are wide variances from lab to lab, so you have to be careful about what lab you choose and make sure that it is a clinically actionable panel, that you're not missing things on that panel, because just like everything else, there's differences in quality between lab and how they've designed their panels. So in general, your documentation for the two will be pretty similar. Make sure that you have, a proper report from the lab with date of service, and documenting, okay, when was the specimen collection done, what treatments the patients has gone through, and then oftentimes retesting if it's a chronic wound and resistant to treatment.
Good. And just kind of on that resistance to treatment, you touched on biofilms, naturally occurring in these chronic wounds. But that's something that, we've talked about previously. I don't remember if it was Yvonne or if it was Blake who touched on, if you don't properly debride and properly treat the infections in these wounds before you put the skin substitute on, you're trapping bacteria and infection on the inside, which is obviously a huge problem. I know you're not a pharmacist and you're not actually making the compounded antibiotics or antimicrobials, but could you just touch on what advantages PCR gives to a pharmacy who might be looking for, looking to make a compounded topical for wound treatment versus, a broad spectrum oral or IV antibiotic going into the formulary for the wound care?
Right. So again, like you said, I'm not a pharmacist, but in general, as I touched on, PCR is going to be much more sensitive. So you're going to miss things with culture. So it could be that you need to use a different antibiotic because there's multiple pathogens present, or you need to use several antibiotics together. But also because these biofilms often, again, they have their metabolism is slow. They're very slow to grow. So a lot of these antibiotics frequently, the way that they act, the bacteria need to be metabolically active. So they target a process in protein synthesis or going through whatever metabolically active process that it's targeting. So those antibiotics are not going to be very effective in those biofilms on pathogens that are low metabolically, right? So it may not be just antibiotic treatments that need guidance, but if they have low metabolic activity, you may need to treat in a way where you need to ramp up actually the metabolic activity and add a substance to increase the metabolic, be effective in treatment. But again, I'm not a pharmacist and I don't do compounding pharmacy. So it may be that you need to treat the wound first, debride. You need to open up that wound, maybe treat to get them out of that metabolic state so that then the antibiotics that they take are going to be effective.
We have a guest question in here. Obviously, we saw a ton of COVID testing during the pandemic. In your labs and experience, how many times are you seeing polymicrobial infections?
So that depends upon what site. So for wounds, it's very frequent. You actually see more than 50% of UTIs, we see that there's more than one pathogen present. It doesn't necessarily mean that it's the causative factor. Sometimes you're going to have, even on some of these panels, like on wound, you might have a bacteria on these panel that is part of the normal flora of the skin. So the providers always have to take the whole clinical picture along with the PCR data, because just because we find something, it could be a contaminant from the collection, or it could actually be a causative factor for the infection. So the majority you're going to see co-infections. Respiratory, It's less than 50%. So it's less likely you're going to have a co-infection for respiratory. In particular, if it's two viruses, you're not going to see that quite as much. Although we did see COVID and flu sort of coming together some. But in wounds and urinary tract infections, for sure, we see it pretty frequently.
Good. And something that we have seen some questions about, it's not necessarily something that is reimbursable by most payers right now, but just to touch on education for the future, can you talk a little bit about NGS, next generation sequencing, comparing to PCR, cost benefit analysis, those types of topics that our providers might be interested in?
Yeah, so PCR is the panels are around 30 pathogens is what I see most labs will offer. The most common clinically actionable bugs they'll put on their panels for a wound panel. And you're not going to be able to pick up pathogens that are not on that panel. So although it's very, very sensitive, you could have a panel that clinically isn't super sensitive because you can't detect what you're not testing for. However, for next generation sequencing, our NGS panels, it's a broad net. You are sequencing everything. It's typically going to be a 16S sequencing. So you're really just looking for anything that has 16S. You're not going to see viruses or things that aren't specific to the 16S gene. But it's a much broader net. You're going to sequence everything that's in that bug. It's very expensive test. You're going to see a lot in there, especially, again, going back to the healthy bacteria that are going to normally be found on the skin. You're going to see a lot of that. So oftentimes sort of teasing out, okay, what's a pathogen versus what's just normal flora that you're going to find in a skin swab. It's a lot of information. It's a very costly test. So the clinical sensitivity between the two, if you have a very robustly designed PCR panel versus NGS, I don't know that there are any published studies out there on it. But I don't believe that the value is really going to be there. It's also not going to be paid for. It could be paid for maybe if you have a chronic wound and you've done everything and you've gone through PCR, you've gone through traditional culture, you've done everything that you can, and if the wound's just not healing, you have some evidence that, hey, this is infected. You can't figure out what's going on. Maybe you could appeal and get NGS covered. But typically right now, there really isn't coverage for it. The labs that do it, I think it's typically going to be cash pay. Those labs oftentimes, I think, are doing it at a loss, and they're doing it because they're baking the data, right? So they'll sell that. Data is useful. We're in the age of data. So they're not doing it because it's from the business perspective, it makes sense for them as a lab to offer NGS, and they're making money on that test. They're hoping they're going to make money on the data that it's producing later, because it's a lot of data because you're sequencing everything that are in those wounds. So I don't think value is there right now. Maybe it will be after costs come down and we have better ways of looking at the data and weeding out the noise that you're going to get in an NGS test versus your very sort of specific panel. So that's just sort of some of my thoughts on the differences between the two. But I don't think the value is there right now, just because of the cost.
Yeah. And something that I think is fascinating. It's not necessarily directly tied to wound care, but it's directly tied to you. I think the lab consulting business that you put together is fascinating. If you want to touch on LabVault, I think some of the providers who either listen to this or watch this would be interested as well. But tell us more about what you do and how our providers and some of our even nursing home administrators or SNF administrators could potentially work with you and the team over at Helix pending tentative rebrand.
Yeah, Helix Molecular Solutions, we're likely going to be rebranding soon, yes, to, I think, 522 Consulting is what we're throwing around. But right now, Helix Molecular Solutions, we've been in operation since 2018. We are a clinical lab business consulting firm. So we work not only with clinical laboratories or lab owners or potential owners, to consult them on opening a lab or improving their current operations. But we also consult for vendors that sell products to diagnostic labs, help them to improve their products, make sure that they're not putting low quality products out there, or these panels that, hey, you should really have these pathogens on this panel and to add these other bugs to be more clinically actionable. But the bulk of our business is helping labs, whether it be through mock audits for regulatory purposes or starting them up from scratch. How to set up their lab, what staff do they need, staffing, lab directors, recruiting people. The big project that we're working on right now and we're managing is a project called LabVault. So right now we have a 9,000 square foot facility. And we have independent labs that we are establishing. They have their own equipment, nothing shared, their own space, their pre and post PCR space. And we're managing everything from helping them to get their lab director in place, managing the staff, setting up all of the equipment and validations, managing their regulatory inspections through COLA and CLIA and whatever state inspections may be needed. We have this facility is in Houston, Texas, just north of downtown. And for potential lab owners that they want to open a lab, but they don't have the expertise, or maybe they're in an area of the country where it's really hard to recruit qualified lab staff. Being in the middle of Alaska or Montana, wherever you may be, it can be really hard to find, in particular, qualified molecular technologists and general supervisors, technical supervisors to manage your laboratory. It's also very, very costly. And there's a lot of overhead. And then you have to have a space in your clinic if you're a physician-owned lab. So this solves a lot of the quality issues and just the it's a lab as a service to manage, and it's like an operations agreement to manage their laboratory that they own in our facility. And they don't have to worry about, hey, did I file this paperwork on time? We need to get prepared for inspection. Our lab director is leaving. We need a new lab director. Are we doing all the right things to have quality results? And all the costly infrastructure that goes into managing the lab, from your software and document control to integrations with EMR, things like that are all handled in this model with LabVault. So it's an opportunity for potential lab owners to have their own lab and not have the headaches that go along with it. And it would be a lot quicker to get started in the lab business because we have everything here that you need, and you don't have to piecemeal it together yourself to have your own lab.
That's incredible. I think, that's something that more and more providers I'm hearing are interested in, having a lab, having direct access, having, a group that they trust. So that's phenomenal. Jessica, can we put Dr. Natalizio's contact information up on the screen just again while we wrap up to make sure that we have that on the video so that anybody who's interested in reaching out to Dr. Natalizio can get her contact information and reach out about lab consulting, because again, it's such a crucial part of the process, not just for wound care, but for so many pieces of the overall spectrum of patient care. Dr. Natalizio, thank you so much for coming on today. It was a pleasure to have you. And for everybody who joined us or is watching the replay, we look forward to seeing you on our next webinar, which is My date math is off. Let me check the date real quick. Our next webinar is going to be on September 3rd. And we are expecting to have a very special guest. They're not quite confirmed yet, but if you are a provider who is concerned about audits and clawbacks, which I know is a major concern in this space, you are not going to want to miss our next webinar. Again, that's 1 p.m. Eastern on September 3rd. Thank you all so much. And thank you again, Dr. Natalizio.
Thanks for having me.